السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على خير خلق الله. I would like to thank the organizer, the sponsors as well for their kind invitation. Today we have a special meeting really under the autopsy of the Saudi Health Council as well as the National Heart Center, and we'll address the understanding symptomatic hypertrophic cardiomyopathy. This talk sponsored by BMS. We'd like to thank them for their continuous support. Our speaker tonight is a very special speaker. He's really consultant, adult cardiologist, advanced heart failure, and adult therapeutic at King Faisal Cardiac Center, King Abdulaziz Medical Center, Ministry of National Guard Health Affairs in Jeddah. Professor Ibrahim Ajledan, he's well known in his field, really leader in the heart failure specialty. He will really address to us a very important topic, hypertrophic cardiomyopathy, a topic which really we have underdiagnosed before and we have undertreated, and hopefully in the next 45 minutes we'll have a chance to hear from him about the definition, epidemiology of a hypertrophic cardiomyopathy, the understanding of pathophysiological mechanism of HCM, the clinical manifestation and the diagnosis, as well as we'll have at last 10 minutes about general management regarding the therapeutic regimen. Hopefully at the end of the talk, we have enough time for discussion. So I encourage all the attendee, please go ahead and prepare your questions. We should have really a lot of questions to our speaker tonight because he's a special speaker and special topic. Please, Professor Ledan, go ahead.
Assalamu alaikum. Thank you, Prof. Muhammad, for this nice introduction. And I will be sharing my slides right now. Can you see the slides very well?
It's seen very well. Thank you. Yeah.
Okay, excellent. So, Bismillah ar-Rahman ar-Rahim. As you mentioned, Prof. Muhammad, today we'll talk about an interesting topic, which is the hypertrophic cardiomyopathy. It used to be called hypertrophic obstructive cardiomyopathy, and I'm going to explain a little bit why the name changed, and actually the cardiomyopathy word got a little bit of more interest, especially with the new European guideline that was published in 2023. Because there still are a group of diseases that are not well understood, if I can put it this way. It's an evolving field because they have different phenotype, and each phenotype now we're learning that although they share some of the outcomes, the bad outcomes that come with cardiomyopathies, but the phenotype, the clinical scenarios, and the way we diagnose and treat them are a bit different. So that's why they are now having a unique guideline separate from the heart failure management guideline. So today, as you mentioned, thanks to the organizing company, it's a series of webinars that's going to be spread over the year. They're going to be talking about hypertrophic cardiomyopathy in details. So today is going to be an introductory discussion. We're going to touch base briefly on what is hypertrophic cardiomyopathy, what are the common subtypes, mechanism of why this disease causing symptoms for patients, how we can diagnose this disease, briefly as well, echocardiographic feature, and what is the role of the multimodality. Then briefly, we'll talk about the management, and hopefully with the next lectures in the series, we'll be delving more into details about the treatments and about the clinical trials. So today is going to be an introductory session. So as I mentioned in the beginning, cardiomyopathy overview. So it's important to identify this definition, which I actually took from the European guideline, because people maybe think in their head that cardiomyopathy is just heart failure. So it's not the issue. Heart failure is the clinical syndrome that patient come with signs or symptoms of heart failure, with dyspnea, with edema, and evidence of structural abnormality on echo. So it's a big umbrella that can enclose a lot of different etiologies. One of those etiologies is the cardiomyopathy. Basically, those are myocardial disorders. So there is a disease, there's a problem in the myocardium itself, in the muscle myocytes, and that structure or a problem cause functional abnormality in the myocardium, and that in the absence of, so this cardiomyopathy is not clearly explained by the common etiologies like coronary artery disease, hypertension, so things that can cause volume or stress overload, valvular disease, and congenital heart disease. So no evidence of those diseases that's sufficient to cause the observed myocardial abnormalities. So cardiomyopathies can coexist with those mechanisms. So you can find some coronary artery disease or some valvular disease or some other diseases with the cardiomyopathy, but they're not that overt to explain the whole picture. So I think that's probably a very important description that the guideline clearly try to explain in the latest publications. And actually, they trying to simplify the phenotypes of the cardiomyopathy. After you look at the imaging and everything else, you can dividing them in hypertrophic cardiomyopathy. So you have a thickness of the LV mass. You have dilated cardiomyopathy when the LV or the RV become dilated. So it's kind of an eccentric hypertrophy picture. You have non-dilated left ventricular cardiomyopathy. So some sort of cardiomyopathy that's not fit with the hypertrophic or dilated one. We have the ARVC. So basically the arrhythmogenic cardiomyopathy. It used to be called right ventricular. It used to be only describe the abnormality of the right ventricle, but because of the involvement of the left ventricle as well, it caused now arrhythmogenic. And also we have the restrictive cardiomyopathy, which is a different entity that involve probably a lot of other infiltrative disorders. So our focus will be with the hypertrophic cardiomyopathy. Just give me a second. Okay. So, and why they are bad? Because they lead to significant complication with time. So with cardiomyopathy, what's going to happen is you're going to have evidence of systolic or diastolic dysfunction that's going to lead to heart failure with time. This abnormal myocytes, regardless of the phenotype, will lead to increased risk of arrhythmias, and arrhythmias can cause burdens of symptoms, so morbidities, and also they can cause sudden cardiac death or mortality. Cardiomyopathy may require intervention for a invasive one for symptoms management. So also that will increase the risk and also increase the burden of the healthcare facilities. So hypertrophic cardiomyopathy is the most common genetic heart disease. So basically, why we said it's not called hypertrophic obstructive cardiomyopathy, because it used to be described as a hypertrophy with obstruction, but now we understand that there's a lot of people who have hypertrophic cardiomyopathy that are not obstructive. So that's why we changed the name to the hypertrophic cardiomyopathy. Depending on the studies, we have a lot of different numbers in terms of the prevalence. In adults, around 0.2, less in children. Genetic variants are reported in around 30 to 60%, depending on the study that you're looking at, but around almost 40% in most of the studies having the disease, but they don't have a specific gene that's can contribute to the disease process. So basically what happened is in cardiomyopathy, there is different feature that's with the hypertrophic cardiomyopathy, you have electrical dysfunction because of the abnormality in contraction. So arrhythmia risk is high. You have the diastolic dysfunction, so risk of heart failure is high. The arrhythmia, when it's high, it can cause more risk of sudden cardiac death. So that's also increased the risk that's with this underlying disease. Basically, the morphological characterization of hypertrophic cardiomyopathy, you have ventricular hypertrophy, some dilatation, but it's not the main feature of the disease. And you have non-ischemic ventricular scarring. That's probably because of the underlying fibrosis that we can sometimes see in the cardiac magnetic resonance. What that lead to? There's lead to systolic diastolic dysfunction, as mentioned, that can cause a lot of symptoms burden and also bad or poor outcome regarding those patients. So let's start by the definition. So hypertrophic cardiomyopathy, what does it mean? Technically or practically speaking, that's mean LVH in the absence of other cardiac, systemic, or metabolic disease capable of doing this magnitude of hypertrophy. For example, you don't have evidence of clear uncontrolled hypertension for years that can explain the presentation, or you don't have evidence of infiltrative heart disease, such as, for example, amyloidosis, sarcoidosis. So something else that explains this LVH that we can see in the echocardiogram. There is there is an ongoing debate about the number that we look for to say this to trigger the diagnosis, because now the guideline is universal across male and female, saying 15 millimeter anywhere in the left ventricle is a characteristic of hypertrophic cardiomyopathy. But we usually take list numbers if the patient have family history or gene positive. And also now there's a discussion about using different cutoff for male and female, and that's probably will increase the sensitivity, catching more patients. Especially we know that it's female is underdiagnosed and they actually do worse than male, as we're going to explain later. So when we look at the echo, as you can see in this picture, you can see the hypertrophy, and this hypertrophy will alter the pathology, the physiology of the cardiac muscle. So it will lead to impaired ventricular filling and diastolic dysfunction primarily, and later on, if the disease left untreated and progressed in life, it can be burned out and lead to systolic dysfunction. So the beginning, it starts with a significant diastolic dysfunction at first. LVOT obstruction occur in, if you look at the studies, there are different numbers, but the range is around 25 to 30% in patient under resting condition. And it can goes up to 70% of patient when you try to propagate the obstruction. So basically, what do we mean by this? But the LVT obstruction is one of the features that we can see in if you can see here in the picture, the LV is very thick. So when the blood is going out from the LV through the LVOT, it will have a gradient or obstructive feature, not in all patients, but in some of the patients. And sometimes at resting condition, you cannot pick up this gradient, but if you propagate the patient by different maneuver that we're going to explain, or by exercise, you can produce this obstruction, and that can cause symptoms that will be pathognomonic of hypertrophic cardiomyopathy. In addition to serious complication, hypertrophic cardiomyopathy cause lower overall well-being because they have a lot of symptoms, including dyspnea, fatigue, chest pain, because we have a thick muscle that's usually cause ischemia, subendocardial ischemia, so different than the obstruction of big vessels, mainly small vessels, unable to meet the demand of the big LV mass, palpitation because of the abnormalities of the LV structure causing arrhythmia, and syncope, and overall maybe can lead to sudden cardiac death. So if you look at the global population, regardless of age, sex, and race or ethnicity, the HOCM is present in most of the people. There is no specific race. It affects men more than women. Is it purely because this disease is more specific for men, or because we're underdiagnosing women because of the cutoff that we're using for the echo? I think that's still an undergoing debate. 2/3 of patients as male, as we said, and female gender was associated with worse prognosis, probably because of the undiagnosed and undertreated and underdiagnosed over time. So they have more than 2 times risk to have worsening heart failure or heart failure hospitalization than male. Average patient at diagnosis usually in the late 40s, but sometimes patient can present early in the 30s, and some people can be presenting later on in their 60s. And although hypertrophic cardiomyopathy is found across different population, clinical phenotype and outcome can vary by race. Some of the variation may be due to social economic issues, not just because of it's affecting different race differently. We need obviously more data to know about this. And the key is that Prof. Muhammad mentioned is it's probably underdiagnosed. So we know from the estimated global studies that it's around 0.16 to 0.23%, but experts suggested that it could be around 20 million people living with hypertrophic cardiomyopathy worldwide. Data from the United States, as we said here, prevalence of around 1 to 500. Other database can estimate globally prevalence of 1 to 200. So it's probably more common than we are expecting, and the experts suggested that probably almost 85% of the HOCM population or the hypertrophic cardiomyopathy population aren't diagnosed. So if we look at the figure down there, you can see the red part, the big red part is the underdiagnosed people who are not being officially recognized and treated, and we're only seeing the minority of those patients. So having a high index of suspicion, when you see an echocardiogram for the patient, you see the septum or any part of the LV, as we mentioned, is more than 15, or in female, probably to 12 or 13. Sometimes simple question about family history and making sure the patient is not like having obvious hypertension and other diseases that can trigger more discovery of those patients and more diagnosis. If we look at the symptoms, basically, the clinical recognition of hypertrophic cardiomyopathy can be very difficult because if the symptoms of the hypertrophic cardiomyopathy are not specific. So dyspnea, it can present with people who are having heart failure with preserved ejection fraction, who are hypertensive, who are having CKD, diabetes, cardiometabolic disorders, obese, not fit. So a lot of the symptoms can be very general symptoms and not specific to that disease, overlap with other pulmonary disease as well. And sometimes it can be subtle signs on echocardiography, so it's not very clear. Some of the labs don't have LV contrast, so you cannot see the part of the hypertrophy. For example, apical part can be missed if you don't use LV contrast very well, or if you have a limitation of the technical aspect when you are scanning patient with hypertrophic cardiomyopathy. So as we mentioned, there is multiple subtypes. So hypertrophic cardiomyopathy can present with or without obstruction, as we mentioned. So LVOT obstruction is the hallmark of obstructive hypertrophic cardiomyopathy, but you can have the hypertrophic cardiomyopathy without the obstruction. It will be present in 70% of the patient, and the definition of the obstruction is having an LVOT gradient more than 30 millimeter mercury, and we can see it later on in one of the echoes that can show how we measure it. Basically, obstruction might only become apparent when you propagate this obstruction for the patient. So if you do the propagation methods and you're not able to increase your LVOT gradient, then probably you have non-obstructive hypertrophic cardiomyopathy. So the estimated prevalence of the non-obstructive, as we mentioned, is around third. So if you can think about it simply, third non-obstructive, third obstructed at rest, and the third you can show when you propagate those patients in the echo lab, and you can discover the obstruction with the echo machine. So how do they progress with time? So hypertrophic cardiomyopathy may progress regardless of the presence of obstruction. So that's why we said it's important to diagnose and recognize those patients, because the presence of obstruction alone is not just a sign of worse disease. Patient also of non-obstruction can have worse outcome. So when we look at the cohort of the patient, around 43% of the patient in this 1,000 patient cohort found to have at least one adverse outcome, and 11% have two adverse outcome, and less than 1% have three outcomes. Bad outcomes, as we mentioned, the most common was heart failure, arrhythmias like atrial fibrillation, and unfortunately can be sudden cardiac death event. Both obstructive and non-obstructive hypertrophic cardiomyopathy present significant cardiovascular risk and poor outcome, including the arrhythmia and the progression to dilatation and eventually end-stage heart failure. The mortality rate is low, but it's higher than the general population, but it's still there. And we can see there that the non-obstructive resting obstruction or provocable obstruction are almost similar. So they are all serious disease, need to be managed. So the LVOT, basically what's happened is why the obstruction happen. So you have a thick myocardium that will make the LV cavity very small. You have also other abnormalities such as the elongation of the anterior leaflet to the mitral valve, and that can sometimes lead to the systolic anterior motion of the anterior mitral valve leaflet. So basically during systole, the LV is trying to empty the blood through the LVOT and the aortic valve to the aorta. So what happens is either it can be obstructed with the narrowing of the LVOT by a thick septum, or the mitral valve will be long, elongated, and moving toward the septum during the systole. So the SAM, basically in systole, the anterior leaflet will be pushed toward the LVOT and will cause the obstruction. And LVOT gradient are often dynamic, so sometimes you cannot see it at rest. And when you increase the heart rate, decrease the volume of the LV, that's probably what we usually do. So decreasing the volume will propagate the obstruction, and you will see it more in the echocardiography. The LVOT obstruction disturbs the cardiac structure and function. So we can see it here in the CMR. It will lead to diastolic dysfunction, gradually leads to an enlarged left atrium, upstream pulmonary congestion, pulmonary hypertension. So all of that will be a sequelae for untreated patients. Symptoms of hypertrophic cardiomyopathy are often attributed to these pathophysiological changes. So that's why the treatment is very important to help with the patient's symptoms. And also, it's important to recognize that not just we think about the classical one that the hypertrophy is in the septum, but it can actually present with a variety of septal morphologies. So we can have people with only sigmoidal hypertrophic cardiomyopathy, so mainly the obstruction in the proximal part, as I'm showing here in the next to the LVOT, or it can be a reverse curve, so it's like curving inside the LV from the septum. Apical hypertrophic cardiomyopathy, when most of the hypertrophy and the problem happening at the apical level, or asymmetrical septal hypertrophic cardiomyopathy, and probably that's a lot of the people we see in the ecolab. So you have to be careful with the subtype and different subtypes. So we have to have a high index of suspicion, especially when we're doing a scan for the patient. That's why it's useful when there is a suspicion to use the LV contrast in the echocardiography lab, which is almost harmless, and it's easy to use right now to recognize some of the other subtypes. And as we're going to mention later on, some of the different other modality can also cause further elaboration on the type of the hypertrophy. So why the hypertrophic cardiomyopathy happen? So basically, it's a genetic disease in most of the time. So until now, we have around 8 genes identified with problems that can cause sarcomeres disturbance that lead to the cardiomyopathy. The most pathogenic variant that located in the myosin binding protein, it's around 57% of the patient. Myosin heavy chain is around 32% of the patient. Other the troponin genes and other myocyte genes are less in terms of the incidence, but most of the patients are having abnormality on those subtypes of the gene. But not all the patient with hypertrophic cardiomyopathy has a gene positive or a variant that we can detect on examination on genetic testing. There's around 40% of people who have hypertrophic cardiomyopathy, and we don't have a clear identification of the underlying gene. And so having a negative gene study, if you have the diagnosis phenotypically, is not going to be ruling out the disease. So that's very important. So basically what happened when you have this variant causes there is a destabilizing of the myosin head. So if you look at the diagram here, it's an easy way to explain it. Normally the myosin motor domain, so the orange one, and bind together with so both the free myosin, both heads, the orange, the maroon ball, bind together. One also binding to the subfragment ST, which is the green one here, in this relaxed state. But if there is destabilization during this disease, they're both not binding together, as we can see in the bottom part of the diagram. So there is more availability for potential active myosin binding. So we have more binding sites available than what it should be, and that will lead. So what does this destabilization cause? So the destabilized myosin head lead to more active myosin cross bridging. So basically, the shift to increase this status allow more active myosin cross bridging to form. This increase in cross bridging lead to hypercontractility and impaired relaxation. So the impaired relaxation, basically, what do you mean by that is diastolic dysfunction. And we know that from the data that we have from HFpEF or mildly reduced ejection fraction, that diastolic dysfunction can cause many symptoms and cause problem as heart failure with reduced ejection fraction. Increase in energy demand because of this increased contractility. So this increased energy demand will cause ischemia that will lead to cardiomyocyte death, and they may lead to heart failure. That's why we explain the presence of fibrosis. So if we look at the histopathology of these issues, if you this excessive cross-bridging also will lead to the disturbance of the underlying structure of the myocyte. So if we see in the diagram A here, we can see a healthy heart tissue. There is organized myocyte parallel to each other, nicely looking. But if you look at the B and C part, they look at the disorganization or disarray of the myocardial fibrils, and that's probably that's because of the disturbance in the sarcomeres that was that explained by the genetic disorders. And also there's when more death happen, there's more fibrosis that can be discovered, as we see in the picture here D. So that's picture showing more fibrosis, interstitial fibrosis in patients with hypertrophic cardiomyopathy. So that's why those patients present with this disease process. But not phenotype does not always correlate with phenotype. So basically, if the patient have gene positive, that does not mean they will manifest the disease all the time. And also not all the patient with positive presentation have a positive gene study. So this is a retrospective analysis for patients they were followed for around 8 years. Around third of the patient with pathogenic variants, so they have gene positive, they did not have clinical signs. So they have phenotype negative, and only a third of them went to develop hypertrophic cardiomyopathy with follow-up. So the prevalence was around, like over 15 years, was around 46%. Different factors influencing this, including age, sex, ethnicity, but I think more information needed. So that's why till now, there is no clear guideline on how to manage patients with positive gene and negative phenotype. I don't think I put it in this presentation, but basically the American guideline now try to simplify it a little bit. So if you have a patient who are positive in terms of their gene studies, but they don't have manifestation of the disease, you can do frequent screening with ECG and echocardiography. In adult, we mentioned it's around 2 to 3 years. In pediatric, maybe we'll shorten the duration 1 to 2 years. Or if the patient is having gene positive, it's around 1 to 2 years. So the guidelines are not very clear, but the idea is you have to keep a close eye on those patients and keep monitoring them, because a big chunk of them will change and will manifest the disease later on in life. So what does the clinical implication in patient with hypertrophic cardiomyopathy? As we mentioned, patients with hypertrophic cardiomyopathy have higher mortality rate, basically because of developing heart failure. They have morbidities like arrhythmias, atrial fibrillation that will lead to stroke if untreated. Overall outcome risk is there for those patients. And basically, the younger patient have a cumulative risk increase over time because they will increase the risk over time. But the patient who develop the disease later on have a higher incidence. So they're a bit showing the disease faster, but cumulative incidence is higher with the younger population. So we'll move on to the diagnosis. So basically, the diagnosis, to diagnose any cardiomyopathy according to the European guideline, you have to have a clinical scenario in the beginning. So you have to have symptoms and sign. You look in the morphological and functional characterization of this disease, understand if there is any other trace like arrhythmias. We're going to mention that in the next slide. Understand the phenotype, and then you can generally manage this patient after identifying the phenotype, because there is specific phenotype management. And if you look in the slide, it will explain very clearly. So if you have a patient that you're suspecting hypertrophic cardiomyopathy or any kind of cardiomyopathy, basically, so you have to have a detailed examination and history taking. So you ask about the symptom, dyspnea, chest pain, palpitation, syncope, presyncope, any incidental finding, ECG finding, as we're going to mention around in the next few slides, murmur on exam, arrhythmias. You do a comprehensive family screening with a first-degree relative of cardiomyopathy and a family tree. Then you can examine the morphological feature for those patients, ventricular morphology, is it hypertrophy, as we mentioned, dilated, etc., and look for other traits that are common with some disease like arrhythmia, conduction disease, for example, in amyloidosis, pedigree analysis in the family, laboratory marker, pathology, etc., and then you will understand the phenotype. So for example, in this case, hypertrophic cardiomyopathy, so you'll be able to manage this according to the phenotype that you are having. So basically in hypertrophic cardiomyopathy, as we mentioned, symptoms, family history, abnormal ECG are the most common things that we usually see, especially in asymptomatic patient. Abnormal ECG, probably in your practice, we will catch a lot of patients with abnormal EKG because they can be asymptomatic. Symptoms are usually symptoms of heart failure, poor cardiac output, symptoms of LV mass increase that cause ischemia like chest pain, palpitation from arrhythmia and syncope, or sudden cardiac death, unfortunately. Age is a factor to consider, and also presence of the family history. So those are the things that you suspect on clinic examination. You can, when you examine the patient, you listen to the Holcomb murmur, the obstruction murmur at the apex usually, and you can listen to a fourth heart sound if there is evidence of diastolic dysfunction. The murmur can be exacerbated by for example, standing up from sitting position because you have a hypovolemia, so you can increase the murmur. Other things that we can look for that from other extra cardiac issues like carpal tunnel, muscle weakness, all of those, if you can see, they are not that very specific, but they can raise the suspicious of hypertrophic cardiomyopathy. Family screening is very important because family history should be examined. You should be collaborating with multidisciplinary team. So medical geneticist is very important in this situation. So ECG, as we mentioned, you can find the typical usually that we see in a lot of the patients, the very bad looking LVH ECG with the depolarization abnormalities, with the T-wave inversion, the strain pattern that we usually mention. So that's very important. So STT wave changes, deep Q waves, deep S wave in V1 and V2, large R wave in V5 and V6, repolarization changes that we call it usually strain problems, and P wave abnormalities if you have problem with atrial dilatation. So those are very useful signs that we can look in the ECG, but the absence of that does not mean the disease is not present. Some of the diseases, specific things like apical hypertrophic cardiomyopathy can present with a giant negative T wave more than 10 millimeters. So those things that we can look in the ECG. Other non-specific finding like heart block, pre-excitation, LV, low voltage can be can be present in any kind of hypertrophic cardiomyopathy, and some stuff that we really need to look at. And you can see ECG is something that will open the door and explore the door for you to look for other modalities, but it's not going to lead you to the diagnosis because you can see there's a lot of similar criteria in different hypertrophic cardiomyopathy or cardiomyopathies. What are the blood works that we ask for? So first level is for all patients. We ask for a CK liver function, NT-proBNP, proteinuria function, troponin. And then if you think about specific disease, you go ask for specific testing like the alpha galactosidase level. If you think about any genetic problems, Fabry's disease, for example, if you look at the immunofixation, free light chain amyloidosis, etc., etc. So you have to have specific labs for specific cardiomyopathy if you're suspecting that kind of phenotype of cardiomyopathy. And that's basically the guideline, just explaining the same thing we're mentioning. I'm trying to move a little bit faster to go to the treatment. So diagnosis, usually we use multimodality imaging. So we will not only use the ECG, we use the echocardiography as well and cardiac MRI to identify this disease more. So basically what we do is when we identify the phenotype, we need to do a lot of the modalities, and echo and cardiac MRI are very useful. Echo and cardiac MRI can identify ventricle function, hypertrophy, dilatation, so understand more of the disease. MRI, if you don't understand things from the echo, it can give you more information. Also, it can help you with risk stratification, looking for fibrosis and stuff like that. Stress echo can help you with having the gradient, showing the gradient, for example. Stress testing will help you with detecting ischemia or even functional capacity if the patient is having heart failure that you need to identify later on transplant or something like that. And different testing for different specific, like amyloidosis, we can do the POIP scanning, etc., etc. So as we mentioned, the LVOT, how we look at that, the LVOT obstruction. So resting obstructive outcome is when you have more than 30 millimeter at baseline. If you cannot find it, you provoke it. And if you still don't find it, you need to do exercise stress echo to see if you're able to provoke the gradient in those population. And if you can see here in the echo, for example, in the left side of the screen, this is we use usually the PW and the CW. So the PW basically basically it's a technique that the pulse wave Doppler to identify where is the level of the obstruction. And then you put your CW to look at the maximum velocity, this late systolic peaking that we usually suggest this is coming from the obstruction, not from mitral gauge, for example. And this is, for example, with Valsalva of 36 and with exercise at 87. So this is what we use in the echo lab with using the pulse wave Doppler, as we mentioned. And this is just the same thing that we're mentioning. So obstruction at rest. If yes, this is resting obstruction. If you don't have, you do with Valsalva. If yes, this is provoked obstruction. If no, then you can lead to do exercise testing. And if it's not proven, then this is a non-obstructive hypertrophic cardiomyopathy. And just a small note, we don't usually use dobutamine to provoke patient because we don't have a lot of data on those patients. Probably exercise is the best way to go. And this is just mentioning that multiple level of propagation can happen when you're doing the sitting to standing Valsalva exercise. So you can increase more of the type of propagation depending on the underlying condition of the patient. And this is basically the guideline summarizing these issues that we just mentioned. So what we do in terms of the management, and I know I'm not diving deep into details, but as I said, this is an introductory talk. So hopefully we can dive deep into details in later talks. So basically, the diagnosis is very important. After the diagnosis, you have to have a multidisciplinary team because you need to identify multiple issues that you need to care with the patient. And it's always a shared care discussion with the patient. So we need multiple people. Why? We need the cardiomyopathy specialist because they can be able to produce or to give the newer medication. They can have a specialist nurse. They can have cardiac genetic counselor, so they have more advanced treatment for the patient. Other related cardiology expert needed, heart failure team, for example, arrhythmia team in case of sudden cardiac death analysis and ICDs, etc., cardiac imaging for doing the MRI, other testing, interventional cardiology, for example, also needed in terms of septal ablation, cardiologists with expert in sport cardiology, for example, needed because those patients are young and have a lot of question about this. Patient support is needed with family carers, psychologists, patient associations, other related specialties like geneticists, pathologists. All those people are very important to help treating patient with hypertrophic cardiomyopathy. Briefly, how we look at the treatment part. So we basically, as we mentioned, according to the guideline, any cardiomyopathy, we look at the clinical scenario, identify the morphological and functional characterization, the traits, and then treats the specific phenotype of the disease. In this situation, we're talking about the phenotype of the hypertrophic cardiomyopathy, especially with the LVOT obstruction and the sudden cardiac death are the main concerns with those patients. So if you look at the pharmacological therapy that we know from previously or from before is the beta blocker. So basically, we're aiming to decrease the LVOT obstruction degree, and that will help with the patient's symptoms. So we usually start with the beta blocker, and those patients, if they're not tolerating the beta blocker or cannot take it for whatever reason, the European guidelines suggest the calcium channel blocker like the verapamil or diltiazem, so then the hydropyridine. Also, they can use the mavacamten, the myosin ATPase inhibitor, because based on the recent literature that the mavacamten is the first-in-class cardiac myosin ATPase inhibitor that may reduce the LVOT grade and improve exercise capacity in patients with HOCM. And if the patient are not responding to all of that, then invasive procedure like septal alcohol ablation or myomectomy is indicated. I will mention now the American guideline and a little bit of the difference that we're looking at. So basically, we are treating patients who are symptomatic and having gradients. So obviously, if you have atrial fibrillation, that's a different scenario. You have to anticoagulate and discuss rate and rhythm control. Then you look at the patient who are having resting or provocable LVOT gradient more than 50. So those patients, if they are symptomatic and having obstruction, then we manage them with the beta blocker, as we mentioned, calcium channel blocker or the mavacamten. If they have heart failure with reduced ejection fraction, we use the usual management of the HFrEF population that we're going to mention and consider the myosin active inhibitor, as we mentioned, in those population. And eventually, if they're ending in advanced stage D heart failure, you can consider cardiac transplant or in some certain situation, mechanical circulatory support device, although it's not usually the typical scenario. So we have to look for the propagation, as we mentioned, and the symptoms, because most of the evidence we have is driven by the symptoms and gradient. So basically what we do is we look for the symptoms. If there is no symptom, beta blocker or maybe considered, but it's a lower class of evidence. If there is symptoms, beta blocker is a class 1. I'm talking now the European guideline. I will discuss now the American guideline shortly. And the European guideline said the patient, if they're still symptomatic, or they cannot tolerate the beta blocker, then you look at the calcium channel blocker, then you move to a second line, and they mentioned that the disopyramide, the vasodilator, or the mavacamten as a class 2A. And if the patient is still symptomatic, you go for the septal reduction therapies. And this is basically a written summary of this kind of management. And we can mention here that the cardiac myosin ATPase inhibitor, the mavacamten, is a class 2A in the European guideline. I'm gonna move this one. And probably this was driven from the multiple trials that looked at the mavacamten trial. So the most common one that we usually look into and analyze the Explorer hypertrophic cardiomyopathy trial. We also had the result of the Valor hypertrophic cardiomyopathy trial, who are patients going symptomatic, obstructive, going for septal ablation, taking the mavacamten. And basically the Explorer trial that examined the mavacamten at different doses versus placebo, it was showing that mavacamten improved. The primary endpoint was basically symptoms driven primary endpoint that was positive in the mavacamten group. And if I just look at the obstruction, you can see that the patient who took the medication, the obstruction was significantly different from the baseline to the wake 30, from 86 to 30 8 millimeter mercury, compared to the a small difference in obstruction in patient who took the placebo. And if you look at the NYHA classification at week 30 with the mavacamten, the majority of the patient had NYHA class 1 and 2, so minimal symptoms compared to the baseline. But with the placebo group, most of them have significant symptoms. So basically, for patients with obstructive hypertrophic cardiomyopathy, this is from the 2024 American guideline, who have persistent symptoms attributable to the LVOT despite beta blocker or non-dihydropyridine calcium channel blocker, adding the myosin inhibitor to adult patient or the disopyramide in combination with those medication is a class 1B right now. And I will show you just the diagram. So basically they're summarizing the issue. So if you look at that, you treat the comorbidity, of course, and then you look at the obstructive physiology. If you have no obstruction, that's a different scenario. But if you have obstruction with symptoms, then you avoid vasodilator, as we mentioned, and high-dose diuretics because you want to avoid dehydration. You use the beta blocker or the calcium channel blocker. But if your patient still symptomatic, then we have multiple strategies at the same level of evidence, including myosin inhibitor, disopyramide, and septal reduction therapy. And the septal reduction therapy, you can explore both options of septal ablation and myomectomy, and that's a different discussion in our talk. So that's hopefully try to summarize a little bit the diagnosis, the multimodality imaging, and briefly the management. I did not touch base on the management details about sudden cardiac death prevention, but I can discuss that in question if there is any from the audience. Thank you very much.
Well, thank you very much, Professor Jaydan. Really, I enjoy your talk. You have very comprehensive, very summary of the whole evidence we have up to now. Now, while we are waiting for the question, let me start you. Why is it important to diagnose the patient early?
So as we mentioned in the diagram, so the problem is with early patient, they have a high cumulative incidence of issues. So they usually develop a lot of poor outcome more than the elderly in life. So they are more prone to having arrhythmias. They are more prone to develop. If you think about it, the physiology of the disease probably will get worse with time, the obstruction. You don't know at what time they will have the burnout, and they will change from the fibrosis will be too much, and they will change to systolic dysfunction. So probably now with those medication, we have if I dare say it, a reversible of the mechanism a little bit rather than just decreasing the obstruction with the beta blocker. So hopefully with time, we'll know more that maybe catching those patients early and treating them can reverse a little bit of the underlying pathophysiology, and that will يعني reflect positively in later on in their improved survival and decreased cardiac outcome, heart outcome in the future.
If we diagnose the patient early, and as you know, the beta blocker usually have their own problems as well as calcium channel blocker. Not only that, but even the disoprolamide has its own problems. So all of them really they are not the best to be started with. How early we can think about the mecantum in the management?
So we need to understand that the medication is still relatively new to the world of hypertrophic cardiomyopathy. So we're learning more with time with this medication. Now we have to stick with the guideline, especially because the trial was designed this way. If we look technically speaking, as you mentioned, first of all, beta blocker have a lot of side effects in younger population. The same thing with the calcium channel blocker. Diazepam, I don't think even I used it before here. I think it's very difficult to find. And if you look at the studies that looked at the beta blocker actually for hypertrophic cardiomyopathy patient, they were like very old studies, very small number of patients. They're not well done compared to the myosin, the mivacamten medication. So I think for now we have to follow the evidence that we have so far by starting the beta blocker. But as you mentioned, if the patient is not tolerating the beta blocker, the guidelines are clearly indicating that you can choose or pick and choose between the strategies. So basically, if your patient is still symptomatic or cannot tolerate the beta blocker, you can move on next to the mivacamten. So it can happen a little bit earlier, especially as I mentioned in the American guideline. Now it's a bit even field if I mention after the beta blocker.
Great. We have a question here. When started screening by image to check the gradient after second line treatment, or only depends on the symptoms improvement. So do we look for the gradient to see how the patient is doing, or should we look as well for the gradient to assess?
Yeah, so we usually do a follow-up echocardiography to look for the treatment. And actually, the American guideline mentioning that we have to do frequent echocardiography to look for decrease. Because if you look at the study, the gradient was decreasing, the patient's symptoms are improving. So we look for both. Patients' response to therapy is important, and that's why we do all of this with time. And also because we have to understand that patients, if they are not responding to the therapy, that still we can consider further treatment, surgical treatment. And also, as I mentioned before, like we don't have a lot of data or understanding of the mivacamten, how it works with patients with severe MR, for example. For example, we know this disease is only not having the LVOT obstruction part, but mitral regurgitation can be present and can be very bad in some of the patients. So we don't understand. I think the representation of the MR in those studies are still need to be more explored. So that's also another aspect that we need to be looking at all the time. So we look for the echo to look for the gradient improvement. We look for the patient clinically, and we keep doing the screening echo every now and then to look for the stability of the disease.
So in the story of the beta blocker for the same question, usually we look for symptoms. Why in Mavicantum we have to look for the gradient as well? Why not just the patient is doing fine? Why we should be concerned about the gradient?
Well, I'm not sure if I think about it this way, but I think it's just probably that will show a response of the treatment, if I can put it this way. So it's not just the symptoms; it's the underlying mechanism of the disease is being altered. So we'll see something with
I
that.
mean, we want to see the gradient down, but should we look
Yes.
for a gradient to be less than 30 or less than 20 for some? I mean, I want to see the gradient down for sure. But in the beta blocker, usually when we do this assessment, we depend on the symptoms, right? Just
Yes.
if
Yes.
the patient is symptomatic or not, right? But
Yes.
do we say in beta blocker we have to reduce the gradient to certain limit?
I don't think we look at the gradient specifically in beta blocker, and the same. I think with the mivacamten is just something we see on the trials and we see on the real life. So I don't think we need to look for it. But if we see improvement of the patient and the gradient, that would be great. If the patient gradient is still very high, for example, and seems to be improving, I think it's reasonable to discuss further option later on, like a septal ablation or something
Yeah.
like that.
Yeah.
Yeah.
Another question from Dr. Halim Shamsan. He's saying to us, Thank you for excellent review. What is the risk of worsening of LV ejection fraction in the patient started on mevacantam? And what is the follow-up protocol, please?
Yeah, so basically there was a small group of patients in the Explorer trial. They had like the LVF drop. It was not that, I think it was around 5% or less. So
Okay.
that's why we usually do a frequent echo to look for the ejection fraction. If there is any drop, we can either lower the dose of the medication or stop. And after the ejection fraction improves, sometimes we can start with a lower dose. I think if I'm not mistaken, and maybe they can correct me from the company, the Saudi FDA is basically requiring a genetic testing for patient, which is not the one that it's not the usual that's done in the trials to look for patients who are more susceptible to having LV function reduction. And actually, the company is helping with that. They're helping to do the genetic screening for the patient to see who are the patients that have the hyperactivation of the enzyme that will cause the medication to accumulate more. So the risk of decreased ejection fraction is there. It's not that high, but it's still there, and we need to be monitored. And it's not like if it's happened, that's a no-no, and the medication cannot be started again. Usually, if you stop the medication and patient improve, you can start at the lower dose, and hopefully you can have the medication safely without a reduction
Do
of
we
the
have
ejection
any
fraction.
certain protocol that we have to follow up, like echo every 3 months, echo every 6 months, or we don't have certain
Well,
protocol?
nothing in my mind, to be honest, right now about certain protocol. I'm trying to look at to the study, but nothing in my mind. So probably
Okay,
it's reasonable every 3 months in the beginning until we know that the patient is stable, and then we'll go from there.
great. What about any blood test in particular that you have to do from time to time to check if anything has changed in the liver enzyme, in the other parameters that you want to check?
So, so also nothing very specific that I know of. Usually we do like every hypertrophic cardiomyopathy patient have to have the level A lab work that I mentioned before. But something specific from the Campton, nothing crossed my mind, to be honest.
Great. Now we have, the hypertrophic cardiomyopathy secondary to sport and exercises. How would you clinically and by electrical ECG, by echo, or even by other modalities, you say this is not really related to patient genetics or to hypertrophic cardiomyopathy, it's related to his exercise habit?
Yeah, I think this is very interesting. And always like we get asked how to differentiate between athlete's heart and hypertrophic cardiomyopathy. So there is multiple things we go from history, physical exam, and ECG and echo. So basically, patients who are athletes, obviously in the history, there's like an absence of family history. There is no family history of hypertrophic cardiomyopathy. So that's something that will make you think about athlete's heart. Most of the time, they don't have that significant ECG abnormalities that we see in the hypertrophic cardiomyopathy. If you look at the echo, their echo, for example, the left atrial size is not that dilated. It's not abnormal. Their diastolic parameters are not abnormal compared to the hypertrophic cardiomyopathy. So you can see the thickness, but it's not causing physiological problem in the echocardiography. Probably if you go into the MRI, you're not going to see the specific pattern for any cardiomyopathy. You're not going to see fibrosis. So I think it's multiple things at the same time. So having a good history, having normal ECG, having normal diastology parameter on the echocardiography, normal left atrial parameter, all of that will make us think more about athlete's heart rather than hypertrophic cardiomyopathy.
Great. Now you mentioned in your talk that patients should be really have multidisciplinary program for management.
Yes.
So do you advise two things I want to say here. One, to have a special referring center or to have a special, let's say, not necessarily to be referring center, but special cardiologist in each center to be taking care of such patient in a center with his own team created by his own people so that they will have a complete comprehensive assessment of the patient and management.
Yeah, I think that's important. Unfortunately, maybe because of the heterogeneity of our healthcare system, so sometimes that's difficult to have a center of excellence or a hub. Like here we have people like with the university hospital, with the Askari hospital. So it's not like the usual. So there is a center of referral. Maybe now with the MOH new changes and the cluster system, it will be like more of a tertiary care center with heart failure clinic. So I think that's the first part. Like, do we have a referral center? I think it should be this way. But if we don't have it this way, I think your approach of having a specific team, like one or two cardiologists, for example, heart failure plus another person who was interested in cardiomyopathy, managing those patients. And actually, when I was training in Ottawa, that was the case. There was like a one or two doctors who are really just interested in HOCM. So they see all of the patients. We don't have that number of patients. So when they have like 30 or 40 patients, they will gain more experience in terms of doing the test, the medication, make it easy for the patient to identify those newer therapies, including patient in trial, clinical trial, for example. So I think, of course, having a specific service inside the cardiology department managing those patients is very important if you don't have a central of excellence or referral that you should send people to.
Great, great. Now, do we have the medicine now yeah, available in our pharmacy? I mean, are you using it now? Is it
Uh,
really already available on the? I mean, can we start and how we can start really?
Yeah, so it was approved by Saudi FDA, I think last year, end of last year. I think it depends on in the institution that you're working on. Like in National Guard, it's non-pulmonary, so we have to ask for like fill a specific form for the patient if they meet the criteria of having symptoms and obstruction and not tolerating the beta blocker or not having enough improvement of symptom with the beta blocker. I usually fill the non-formulary medication and have the medication brought by National Guard. I think it's going to be different depending on institution. I'm not sure if anybody of the company have any more insights on that, but hopefully this year we'll have more patients in Saudi taking this medication.
Great, great. Now the starting dose, as you said, is 2.5, and then we
Yeah.
can build it up to what I mean, what to make you to go to a higher dose? I mean, it's just the gradient, the patient response, the what is, I mean, how we go from 2.5 to 5 to 7.5 to the next dose.
Yeah, the trial did it actually on the patient response and the symptom. Basically, that's what the way we'll go with. As I mentioned, we're still asking for the medication to treat the patient. Still not a lot of experience with it so far, but hopefully we can have more with time just to know the practicality of the medication and how we can increase the dose. Yeah.
Great. Well, I'm looking for any more questions from our audience. There is nothing here. So what I want to do in the last 2 or 3 minutes, just to give us a take-home message. What should we say to our people here? We have almost 35 attendee. What a take-home message that we should carry them to take that for about this lecture in particular regarding the diagnosis and management. And hopefully for future we have more sessions about medicine and the trial has been done on it.
Yeah, so if I want to summarize it, first of all, have high index of suspicion of diagnosing hypertrophic cardiomyopathy. So when you see a thick myocardium on the echo, try to look into the patient more and do the comprehensive assessment suggested by the guideline to identify the phenotype of this cardiomyopathy so you can identify the patient early and correctly characterize the patient under which phenotype so you can correctly manage the patient. So that's the first thing. Utilize your multimodality imaging for sure. Like we now have a lot of centers with cardiac MRI, with 3D echoes, with LV contrast for the echoes. So utilize all the resources that you have, and especially for the propagation for the LVOT obstruction. We see it a lot, this mistake. They do the echo at rest and they don't do the propagation method. I think real world data, there is like I think more than 40-50% of people don't do the propagation testing. So that should be a no-no, like should be a protocol in each echo lab to do how come patients in a specific way, do the propagation for each patient. So that's the second issue. So in terms of diagnosis, the third one in terms of the management, be active with your patient. Don't wait a lot. We have now therapies that we can use that we didn't have access to in the past. So if the patient is not responding to the first line therapy, now we have more options such as mivacamten, and also the like a lot of the center in Saudi now are doing like septal ablation very well actually, and it's less invasive than cardiac surgery. So that's also things that need to be considered.
Well, I would like to thank you very, very much, Dr. Ibrahim. It was really very important talk tonight, very comprehensive and very summarizing all the data. I would like to thank Mr. Microscope for their sponsoring this meeting, and I would like to thank as well the Kunuz Heritage for their arrangement of it, and the Saudi Medical Council, the National Heart Center for their support. All the best, and we'll see you very soon, inshallah, another lecture. Take care and
Inshallah.
all the best. Assalamu
Thank you,
alaikum wa
Muhammad, and
rahmatullah.
thank you everyone for listening.